Hi, my name is Zachary Town, and as part of the Health Equity curriculum, today we will be discussing substance use. So, as expected, today's objectives focus on substance use and substance use disorder, as well as both the individual and societal impacts. As we go through, you'll learn how to screen patients for substance use and how to use proper language to reduce stigma in the clinic. Please make sure to look at the other curriculum resources on the syllabus to cover all of the objectives. So in order to discuss what substance abuse disorder is, we need to define what are substances. So substances can refer to psychoactive compounds that can cause potential health and social problems. There's a myriad of categories. I just listed a few below. Some legal substances include alcohol and tobacco. So we're talking about wine or beers or liquor, along with cigarettes, e-vapes or cigars. Some illegal substances can include marijuana, depending on the state. It is illegal in Connecticut. And then LSD or heroin or cocaine. And then finally, we have controlled substances. So these are substances that have some therapeutic quality to them at times. And those can include opioids, benzodiazepines, and barbiturates. So, for example, Oxycontin, Vicodin are opioids, and then Xanax and Valium are benzodiazepines. So now we can describe substance use disorder as a problematic pattern using substances that result in impairment in daily life or notable distress. Now, there are 11 criteria that are categorized into 4 main groups, those being impaired control, social impairment, risky use, and pharmacological dependence. And I just want to point out that not all substance use is a substance use disorder. Having one alcoholic drink within a week is substance use, but that's not a disorder. And then ideas like tolerance and withdrawal will be further explored in the Khan Academy video posted. The image below just further breaks down those 4 categories defining substance use disorder into those 11 criteria. And so just take a moment and familiarize yourself with it. At this point, you may be wondering why we're spending so much time discussing substance use. Why do we care? Well, let's start off with the fact that in 2018, 60% of the US population used at least one substance within the last month, with about half the population having at least one drink of alcohol. While that may not seem like an incredulous idea, data from the 2018 National Survey on Drug Use and Health conducted by the Substance Abuse and Mental Health Services Administration found that in 2018, almost 250,000 people in Connecticut struggled with substance use disorder within the past year, and a staggering 20 million people within the US. That places the prevalence of the substance use disorder around 7.4%, or roughly 1 in 13 people. Perhaps more important than the prevalence may be the number of people who want to quit but don't receive help. 68% of adult smokers report that they want to quit smoking, yet 4 out of 9 adult smokers do not receive advice to quit from their primary care physicians. This means that we have plenty of work to do in order to help make our patients healthier. So while the last slide focused on outcomes to individual health, this slide here highlights the cost of substance use disorder to society overall. It should be noted that the full calculation of costs have multiple factors, and so it's difficult to fully calculate. However, if we look at healthcare based on the estimates provided, we see that healthcare has an estimated cost of $236 billion, whereas the overall societal cost is over $800 billion. One of the objectives for today's session is knowing how and when to screen for substance use disorder, and so I thought it was wise to discuss some of the risk factors associated with it. So we can break the risk factors down into a few different categories: individual risk factors, relationship risk factors, community risk factors and society risk factors. And on this slide, I think it's just important to note that when discussing individual risk factors, genetic predisposition does not mean an addictive personality, but rather how certain receptors and cellular processes within your body may respond to the substance itself. And now let's describe some of the outcomes associated with substance use disorder. So we have medical complications, which can present as acute or chronic problems. And this list is not exhaustive. These are just to demonstrate some of the outcomes. As part of acute problems, we have overdose, also tissue infections and psychosis. And then those chronic problems include hypertension, a variety of cancers, cardiomyopathy, HIV, and then hepatitis B and C. Now, the familial impacts can include intimate partner violence, exposure to children, so exposing the children to these substances, and then STIs. And then with mental illnesses, it's been noted that people with substance use disorder have a 2 times risk of having mental illness, and then vice versa. People having mental illness have a 2 times risk of having substance use disorder. And then with depression, it's seen in half of those who use substances, and there's also a noted increase in the risk of suicide. So the next few slides will focus on when and how do we screen a patient for substance use disorder. But before we bring up that idea, I wanted to discuss the prevention paradox. So while we may focus on the patients with the most severe use disorders, there'll be many patients that will be at a small risk for medical and social consequences. These low-risk patients, when combined, place a larger health burden compared to the small number of patients who are at a higher individual risk. And this just highlights the idea that we should focus on screening all the patients who come through your clinic. So hopefully by now we've established a good reason to care about our patients with substance use disorder. But when do you begin a discussion with the patient you're concerned about? Well, the prevention paradox would tell us that many of our patients will be at low risk for substance use disorder, and that we can have a great impact by helping them. So in this sense, we should screen just about anyone for substance use. However, there are also some specific circumstances that indicate we should screen our patients for substance use disorder. I'll list a few of them on the screen, but be on the lookout for new or recurring issues at work or school, or with family or legal issues, a history of trauma, either causing or sustaining violence, and then physical signs like soft tissue injuries at possible injection sites, or sexually transmitted infections, or just laboratory signs could also indicate substance use disorder. Now that we know the when, we can discuss how to screen for substance use. One of the tools we use is going to be called the SBIRT, standing for Screening, Brief Intervention, and Referral to Treatment. So right now, obviously, we're focusing on screening, determining the severity of the problem. From there, we may provide some brief intervention that increases the motivation for change or establishes a plan for change. And then depending on the intervention, we may provide a referral to treatment so the patient can access specialty care with more extensive services. This whole idea is designed to quickly assess the severity of the substance use and then provide that brief intervention for those who are at risk. And the entire screening can start off with a single question. How many times in the past year have you used an illegal drug or used a prescription medicine for non-medical reasons? Now, there will be some clarification if the non-medical reasons is needed, but beyond that, this is your first screening question. So let's say your patient said, yes, they have used an illicit substance in the past year. Then we can go through what's called the DASS-10. And so you can see that includes 10 questions that can be scored from 1 to 0, going through different circumstances regarding drug use, or circumstances around drug use, or outcomes.
And now finally, we can score the DAS-10. So you're going to give 1 point to every yes answer with the exception of question 3. For question 3, it will give 1 point to the no answer. And I want to reinforce that you don't have to memorize these questions. You'll be able to access them within your clinic. I just want you to have a familiarity with them. So anyways, low-risk patients will score 0 points. And for them, we just want to reinforce the healthy behavior. Moderate risk would indicate 1 to 3 points scored. And for these patients, we want to monitor and then reassess them later on to see whether or not their score changes and whether or not they're at increased or lessened risk. And then finally, scoring 4 or more points may indicate substance use disorder or dependence. And for them, these patients would require brief counseling, and we might negotiate a plan as to how to change or refer them to treatment.
When screening patients and discussing their behavior in general, you need to be aware of the implicit biases you may bring to the interaction. These implicit biases are just that, attitudes or perceptions that we may not be aware of, yet may change how we interact with people. In the United States, substance use has had a long history of discrimination that has established a negative implicit bias to the general public. Most commonly, substance use disorder has been associated with serious moral failing of the people using, and that they're inherently worse than the general public. The idea is made worse by impacts that substance use disorder can have on both the individual and the society they live in. This is the stigma that people with substance use disorder face and may lead them to avoid the discussion of their disorder with people who they feel will judge them negatively. To help our patients get the care they need, we need to help remove the stigma from the discussion. This requires the use of language that supports our patient. To this end, words like abuse, addict, and alcoholic should be avoided, while words like substance use, recurrence abuse, pharmacotherapy, and long-term recovery have positive associations and will help patients seek out care.
And related to this idea of stigma in language is something called people-first language. So you see that stigmatizing language can be used in social communities, and that because of this, people will often avoid treatment. And so what we use to help promote treatment is something called people-first language. It's a way of communication that emphasizes the person rather than the condition. This helps to normalize the condition and convey that the person is more than just the condition that they have. And so we would say someone has a substance use disorder rather than being addicts, in the hopes of normalizing substance use disorder, and then also making the person feel supported in seeking out treatment.